Good afternoon, everyone, and welcome to the annual Dr. Martin Luther King Jr. Commemoration and Award Ceremony. I am Marlena Duncan, and I serve as the Vice Chancellor for Diversity and Inclusion here at UMass Chan Medical School. I am so grateful to be in virtual community with you today, to recognize Dr. King, who is remembered most for his commitment to civil and human rights. Dr. King answered the call to serve humanity, and he sacrificed his life for our democracy. But as we pause and reflect on the life and legacy of this great hero, let us not forget he was a human being just like you and me. He was a partner, a parent, sibling, friend. Dr. King was not a superhuman. He was a man who put his gifts to work for the good of humanity. And I truly believe if he were alive today, he would continue to remind us that we all have gifts to share and a role to play in creating a more equitable and just society. He will remind us to examine ourselves and ask, what are we doing to make a difference? And he will remind us that through service, everybody can be great because everybody can serve. Unfortunately, we know too well that Dr. King's work is not done. So as we listen and learn from our speaker today, and we celebrate the achievements of the award recipients, let us also make time to examine how we can use our time and talents to be part of the movement to end racial oppression, class exploitation, gender discrimination, health inequities, and other social ills. Our willingness to study, organize, and act will be the most outstanding tribute we can pay to the legacy of Dr. King. So I hope that today's program inspires you to reflect on ways you can serve better, to build a more equitable and inclusive community here at UMass Chan and beyond. So now I'd like to introduce our Assistant Vice Chancellor for Diversity and Inclusion, Dr. Lynn Hernandez, who will introduce our keynote speaker for this afternoon. Thank you.
Thank you, Dr. Duncan. Hello, everyone. I'm so delighted to see so many of you here today to honor Dr. Martin Luther King's legacy. Today, I have the privilege of introducing our keynote speaker, Dr. No Mayendo. Dr. No Mayendo is a public health physician, health equity strategist, and justice advocate. He currently chairs the Department of Community Health and Social Medicine at the CUNY School of Medicine. Prior to being at the CUNY School of Medicine, Dr. Mayendo served as Assistant Commissioner for the New York City Department of Health and Mental Hygiene, where he developed and implemented strategic approaches to advance overall population health and well-being using a racial equity and social justice lens. He also co-led New York City's COVID-19 Equity Action Plan, including spearheading the formation and implementation of COVID-19 neighborhood response teams. Dr. Mayendo has also served as the Senior Director of Community Health and Wellness at the National Urban League and as a subject matter expert with the Office of Refugee and Immigrant Health at the Massachusetts Department of Public Health. He has served on numerous advisory committees addressing health equity and disparities for the federal government, the Congressional Black Caucus, the Robert Wood Johnson Foundation, the Obama administration, and many, many others, and has received prestigious awards, national awards for his leadership and organizing efforts. There are so many more accomplishments that I can list, but I don't want to keep you away from hearing from him anymore. So with that, I ask you all to please help me give our keynote speaker, Dr. No Mayendo, a very warm welcome.
Thank you very much, Dr. Hernandez. I very much appreciate it. And I thank you very much also, Vice Chancellor Duncan, for this invitation. I'm grateful to be here with you all, and I celebrate not just Dr. King's legacy in this talk, but I also am excited about the awardees who are receiving awards for the work that they've been doing and are being recognized today, and the whole UMass Med community. So I will just go ahead and share my screen. So my talk today is about advancing racial health equity through community health. I think we'll just start off with a review, just looking at, not to be too forensic here, but there's a quote that's attributed to Dr. King from a 1966 speech that he gave in Chicago at the Medical Committee on Human Rights, at the Medical Community on Human Rights Convention. And the quote goes, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." While no transcript or written evidence of that speech has been shared. I think has been found or shared. What we do know is 2 days prior to the speech that he gave in 1966, he was at a press conference speaking about the issue of health and the civil rights movement, and the quote there that he was quoted as having said was, "We are concerned about the constant use of federal funds to support this most notorious expression of segregation. Of all the forms of inequality, injustice in health is the most shocking and the most inhuman because it often results in physical death. I see no alternative to direct action and creative nonviolence to raise the conscience of the nation." So again, here, just to sort of briefly tease out some language here. Now, we don't know whether in Dr. King's mind there was the difference between health and healthcare that we all understand, meaning beyond healthcare delivery and the healthcare delivery systems, really thinking about health in the broader context of how we consider health, the social determinants of health, the structural determinants of health, and how they're interwoven with so much else, so many other aspects of life. But we can note from the kind of work that he was involved in addition to this advocacy around better access to healthcare for all people, he was very much involved in work around employment, work around human rights, work around housing conditions. And he, in fact, was killed while supporting union workers in Memphis who were protesting around really horrible work conditions and horrible pay and so many other things that were going on at the time there. So that one distinction there between health and healthcare, I think it's important that what was actually noted in his speech, it was noted out coming from him, was the issue around health, not so much on healthcare. The other thing was he was quoted and in the press conference as saying inhuman, speaking about inhuman, not inhumane. The initial quote that I mentioned that is widely used now sort of appeared in the media about 2 weeks later, but what was heard at the time was him referring to inhuman, the injustice in health being the most inhuman. And there's an important difference between inhumane and inhuman. Inhumane really speaks to a lack of empathy and a lack of concern about the suffering of other people. Inhuman is a much more egregious thing. Inhuman speaks to the dehumanization, the denial of humanity, and all of what that opens up. You know, when people are dehumanized, it opens up the door to all kinds of atrocious, egregious things, including all these injustices that we're talking about. But even worse, we've seen genocide, we've seen colonialism, we've seen other things where we've seen chattel slavery, we've seen all of these things that are only possible once the doorway of dehumanization is normalized and is accepted. And then the other piece to this is that he referred to the fact that it often results in physical death. It often results in mortality. And I think the importance there is for all of us who are in health. I think we understand that very clearly, and I think it was an important piece to include in the words of Dr. King that are often remembered when we think about him and the work he was doing in health. And then the last thing about direct action and creative nonviolence to raise the conscience of the nation, I think speaks to what Vice Chancellor Duncan mentioned in her opening remarks and about some of the work that's going on in the health equity movement globally, because these things do have global reach and global impact and a collective global history. So with that sort of a little bit of unpacking of words, history matters. We shouldn't be ahistorical, words matter. And how the story is told, how the story is received, who tells the story is very, very important. And from what is documented coming directly from Dr. King is the quote, that the two quotes that I have, the lower quotes on my slide. And I thought I should share those with you. This here is just speaking to the work that we mentioned about Dr. King and the work around employment and housing and poverty and income inequality and the right to a decent life. and all of those things that we now understand are tied in to health very, very closely. And if we're not addressing those issues, the holes in the bucket in health are too large for us to hinge everything we do around healthcare delivery and people, patients following through on plans of care and filling their prescriptions and keeping their appointments and all of those. Those are maybe the center of what we do, but we should be centering it and really focusing on all of the other pieces as well, especially for communities that have been minoritized, marginalized throughout history. This image here, this graphic here is from a colleague, Dr. Mindy Folilov from the Columbia School of Public Health. Really shows when we think of the arc of history in this country, I think we need to recognize that it's only been in a very recent history that we've actually had even legislation that that put aside some of the racist foundations of everything that has transpired in this country for the last several hundred years. And it's important to note because it is, even in the era that we live today, those gains since 1954, those gains are even today in the Supreme Court and at the state level and at local levels are constantly being challenged. And the work to sustain those gains is a task for all of us. And also just quickly to point out that racism can be considered in the 4 categories of internalized, interpersonal, institutional, and structural. Internalized is what an individual carries with them based on the experiences that they've had and how that translates in how they interact with life. And how they react and how they deal with things in their lives. Interpersonal is the experience that a lot of people think of when they think of racism. They think of that racist encounter that somebody may have experienced. Institutional obviously is institutional, and structural takes all of the institutional systemic pieces together in an interwoven way, and how they all sort of mutually reinforce white supremacy. And oppression on one hand, and obviously advantage, supremacy and racial privilege on one hand, and racial oppression on the other. This here's an image here, and we're about to talk about New York City much more so going forward. So now this image here is from 1661. This is soon after the Dutch had colonized what was previously called the island of Manhattan. By the indigenous Lenape people of the area. When the land was colonized and African people were enslaved and brought through forced labor to come and build up the area for commerce and so on by the Dutch. The tip of Manhattan, lower Manhattan, in the Wall Street area, as a matter of fact, the horizontal line you see that demarcates the right part of the tip of the island on the right side of the map, and the rest of the island on the left side, was a wall, a fortress kind of wall to sort of protect that area where the Dutch colony was concentrated. And that is now actually what we call today Wall Street. But when the enslaved Africans petitioned for land so that they could grow crops and have space to live and to have their families and so on, they were apportioned land outside in those sort of green carved, those green demarcated areas on the left side of the wall. And those green areas, essentially what that was the beginning of was racial segregation by residents in the city of New York. So the rest of the island, inhabited by the Lenape people, the indigenous people of the land, those carved out areas by enslaved Africans, and then the protected area where all the commerce and all of the resources were concentrated in the lower tip was resided in by Dutch people and other Europeans. And that has continued throughout the history of the city. The city is one of the most unequal cities. So East Harlem is a place I've done a lot of work, is a place that I want to focus on in the conversations that we are having today, the conversation we're having today. East Harlem is one of the major groups in East Harlem are people of Puerto Rican descent, and also people of Black people living in East Harlem. And how did we get to have that demographic mix in East Harlem? So going back to 1898, at the end of the American-Spanish War, the Spanish-American War, when America defeated Spain and claimed territories such as Puerto Rico and the Philippines and others. Following that, the devastation of that war, there was a wave of influx of what were migrants at the time, immigrants, I'm sorry, coming from Puerto Rico at the time. They were not yet US citizens. There were subsequent waves, including in the 1920s, right after the Jones Act was passed in 1921, that gave partial citizenship to people living on the mainland Puerto Rico. As you know, these are US citizens, but for instance, their vote in Congress almost they don't have the same voting power in Congress, and they're unable to vote directly for the presidency of the United States if they live on the island of Puerto Rico. So, and there's many other things as well that sort of really demonstrate the two-tier system where they are citizens but without the full citizenship. And then following World War II, there was another move of influx of people from Puerto Rico who were moving to the US and to New York for a better life. And some of these newspaper cuttings, the clippings, are essentially to sort of show some of the language and the considerations at the time. And there was a lot of concern, and there was some of it really excessive in terms of thinking about them as coming with diseases and coming coming in and creating crime and being involved in other so-called vices and other things like that as they moved into the city. Yet the community mobilized, the community continued to organize and establish a very rich and strong presence in the city of New York. It's important to note that during this time period, just to sort of show where the medical community can get it wrong sometimes, even using data and all of the different things that we do, and in the name of the work that we try to do as as health professionals. So Dr. Cornelius Rhodes, Harvard-trained physician, he was a hematology oncology specialist. He was sent by so after the Great Depression, it was a very slow economic recovery all across the country, but noted in Puerto Rico especially, there was a very slow economic recovery. And it was considered that this was due to an issue around anemia. And so he was sent to go and study this and see if widespread anemia was the cause of all of this lethargy and a very slow, protracted recovery. And so he went to Puerto Rico. He was one of the, he's considered one of the sort of founding fathers of modern cancer treatment. And he was one of the, I think the founding director actually of what is now the Memorial Sloan Kettering Cancer Center in New York City, world-renowned cancer center offering great services and excellent services and known for that all around the world. But he was one of the founding people. But when he was there, I don't know what happened, but he became very unhappy apparently with the people of Puerto Rico and wrote a letter to a colleague in New York describing his experience. And some of what he was quoted to have written was the island is a beautiful place, but the problem is it's full of Puerto Ricans and they're dirty and they're thieving. They're one of the worst races that inhabits the planet. And the best thing to do for Puerto Rico would be to totally exterminate the population by tidal wave, is what he implied in the rest of his letter. And he said, I've started that already. I've killed 8 of my patients, and I've tried to transplant cancer into 13 more, although none of them have died yet. So this letter somehow was left somewhere where it was discovered by people, and it was shared with Puerto Rican nationalists who then exposed it nationally. It became a very embarrassing situation. It was not fully investigated at the time. He was clearly protected in a government cover-up. And he was, he moved back to New York, and that was the end of that. In World War II, part of his contribution was helping to develop chemical weapons that are now, many of which are banned now in terms of the global the International Covenants on Warfare, but he developed those, and then they were transitioned obviously into cancer treatment. But he continued to have a really stellar career in cancer research chemotherapy, and the American Association of Cancer Research named an award after him in 2002. This whole thing was opened up again in 1978. I'm sorry, the award was named after him. The whole chapter was reopened. This whole case was reopened and investigated by the same association, and they decided that although it seemed unlikely that he did any of those things he said he wanted to do or had done, they felt it was a bad enough look that they should rename the award. And I raise this only to say there's a lot of privilege in the health field and for health professionals, and how we wield it, how we use it really matters. But also to be aware that amongst our colleagues, we don't know everyone's views on different things. But that's why it's important for us to be able to be a voice. If you're a colleague of somebody or an institution that needs to change some of the things that it does and so on, maybe they're not as blatant as this, but maybe they're more subtle. Maybe they might even be more widespread and just just more subtle, or whatever the case may be. But the point is that it will take for other people, other health professionals to speak up and counter the voices of the health professionals that we don't agree with. So looking at the Black community in East Harlem, they came to East Harlem largely following the intensely dehumanizing experience of Jim Crow in the South that moved from just being segregationist to becoming very violent, and people fled north in the Great Northern Migration, moving from the Deep South to cities all across the Northeast, the Midwest, and even out west. And this is a landing site in Harlem where a lot of people were arriving from the Deep South and trying to find work and housing and so on. And then right after that period, we go into the period where redlining sort of was birthed, officially birthed. And through federal code, we know already that Woodrow Wilson, as president after World War I, had started to really advance some of those southern segregationist laws all throughout the country, and including in the North, and that became a really big problem. But so one of the things that came out of the Great Depression was that homeowners had the greatest economic resiliency. They were able to bounce back soonest, and so the Federal Housing Administration was formed, and with the intention of making homeownership achievable by more people. And so they contracted out to the Homeowners Loan Corporation, and they had gone. The HOLC went and did these maps in about 250 cities across the country, where they mapped them and they color coded them based on desirability for investing for housing financing. So whether it's buying homes, building homes, renovating homes, upgrading homes, maintaining homes, and all of that. And one of the keys was that any neighborhood that had 51% or more Black residents was automatically deemed hazardous and redlined and sort of colored in red. And so that was one of the ways in which all of this happened. And so in Manhattan, you can see on the left side, that's the northern tip of Manhattan. And what you're seeing in red is East and Central Harlem, which is sort of the neighborhood I'm just talking about now. And the populations that live there, predominantly Black and Latinx, Black and Puerto Rican in those neighborhoods. And you can see on the right side, the Lower East Side of Manhattan, which includes Chinatown and places like that with a heavy Asian population. They were also redlined. And this here sort of is one of the reports that the HOLC put out for the East Harlem location. And you can see, if you look at the clarifying remarks, it says the main business streets, 125th Street, 116th Street, 3rd Avenue, Park Avenue, Lexington, 5th Avenues, Negro slum district, mostly low-grade tenements, major part of rentals in low bracket. And if you look at number 4, it says availability of mortgage funds for home purchase, none. Home building, none. And this really set up, and then the same for another part of Harlem, where it talks about, in the remarks, it says considerable demolition necessary before district can improve. But the same thing around the mortgage funds availability was none. And then if you skip forward a few decades, all of this, just sort of showing how these things grow, all of these things contribute together. What we're looking at here is in the 1970s, the city of New York was in a severe financial crunch, a severe financial crisis. Federal funds had to be cut back. The state funds were also cut back. The revenues tax revenues had reduced significantly, and the city was looking for ways to save money, as can be as is obviously makes sense. They hired the Rand Corporation to prepare recommendations on what to do, and the Rand Corporation used this algorithm that recommended the shutting down of firehouses in neighborhoods in the Bronx, in Harlem, and parts of central Brooklyn, North Brooklyn, so places like Brownsville, East New York, which were again very heavily concentrated with low-income Black and brown people. And what ends up happening, these are the same places where the buildings are already dilapidated. And whereas in neighborhoods, more affluent neighborhoods that are not highly densely populated, and they have single family homes and so on, that are less at risk for fires, those places kept their firehouses, even though their utilization was very, very, very low. And these neighborhoods that needed the firehouses did not have them, and the fire department's responses took longer than than would have been the case, and a lot of these buildings were destroyed. In certain census tracts in the South Bronx, somewhere in the region of 95% of all the apartment buildings were completely burnt out and not fit for human habitation. And so what we saw was 600,000, it's estimated 600,000 residents of the Bronx forced to move from the homes that they had, the apartments that they had lived in, and having to move in with, concerned neighbors or relatives or whoever would let them in the adjacent neighboring neighborhoods, many of which were also at risk for these same things. And so some families kept moving. We know of families who were displaced by apartment fires 3 or 4 times in the last generation, and has happened again as recently as 3 years ago, people living in public housing. And so a great book about this, written by Joe Flood, that you should check out if you get a chance. The World Series 1977 was being played at the Yankee Stadium, and there's a famous shot that the camera sort of pulled out, the helicopter that was or whatever was recording this, pulled back the camera and took a shot of fires going on in the Bronx, and the commentators were heard saying, the Bronx is on fire. And so, and this is the devastation. So here are children, here are families just trying to live and do the things that we as health people would be encouraging the children to do, which is get out, be physically active, engage with your social peers, build networks and so on. But this is the conditions in which they're doing it. And these are the conditions in which parents are trying to raise children, in which newborn babies are being born, elderly people are aging in these types of conditions. And then fast forward to the 80s, when HIV hit New York City, came with it a resurgence in tuberculosis. And if you look at the map in this newspaper clipping, it's the South Bronx, East and Central Harlem, the Lower East Side, Central Brooklyn, the same exact places that we've talked about as having been redlined, and all of these other discriminatory practices and policies, racist practices. So how did it end up affecting this? So what we found was overcrowding, partly due to people having to move and overcrowd in those spaces because there are so many burnt out apartment buildings in these neighborhoods, that it was social distancing was not something that could be done. And people ended up developing TB. And what we saw was with the high number of cases, we saw the strains also, we saw the mutations, the variants, the strains that were coming forward that were very, very deadly. And this became a big priority for the New York City Health Department, and hundreds of millions of dollars spent for a decade and a half trying to bring this under control. But sort of the link to all of this, and if you look at the racial composition of how the TB was affecting New Yorkers, you can see sort of the same pattern through. And this continues, this whole, everything I'm sharing with you extends to life expectancy, to Dr. King's words about mortality, premature mortality. And looking at life expectancy, the same neighborhoods, the one that's circled is Eastern Central Harlem. And then across from there is the South Bronx, huge swaths of the Bronx. Then you can see Central Brooklyn, the northern tip of Staten Island. And these are neighborhoods, so it's not just life expectancy. If you look at non-communicable diseases like diabetes, it's the same geographical area, the same populations. Communicable diseases like AIDS. If you look at infant mortality, you look at asthma hospitalizations in children, you look at hospitalizations for drug use. It also extends to social outcomes as well. So incarceration, educational attainment, and other things are all sort of mapped almost exactly on the same map. And then if you look at this map here on the left, the blue map, sort of shows the areas that are marked off as being areas where there's a shortage of primary care. And you can see it's the same. If you look at Manhattan, the borough of Manhattan, it's the northern tip of Manhattan and the Lower East Side. So the northern tip where a lot of Black and brown people live, and the Lower East Side, that little corner where a lot of Asian people live and who are also being gentrified now out of those areas. And then the map on the right side shows you the constant, so the darker brown areas are where the asthma ED visit rates are the highest. And then clustered in there, the little yellow spots are where the public housing developments are concentrated. So what happened was, not only was there shifting of resources out of these neighborhoods, there was also not only clustering of people of color in those neighborhoods, but there was also clustering of low-income housing. And a lot of those houses are built right in floodplains. They're built right in heat bubbles. The urban heat island that affects the whole of New York City is much more concentrated in some of these neighborhoods. This is where the Cross Bronx Expressway and many of the other infrastructure, the elevated trains, the bus depots, and they're huge bus depots, are concentrated in these neighborhoods that are heat trapping, heat producing. You'll also see less parks and green spaces and so on. And so the environmental impact of all of this, the flood, the areas that are built along flood, the flood zones, and all of these things, these are all systemically, these are things that are at the policy and system level and creating ill health that we are seeing. If you look at the map on the left side shows you the concentration of people living below the poverty line, the deepest red, it shows you that. On the right side, the map shows the deepest green, shows you the neighborhoods that are mostly concentrated, the highest concentration of Black and Hispanic people living in those areas. And it's the same geographical areas. Now, this is something from 2021, early 2021. And I want to show you that the mapping, unfortunately, sort of follows the same track. And so if you look at the map on the left side that's in red, bright red, I guess, that's the map showing infections, the 7-day positivity. I believe this was in March, I think. And you'll see that the areas in the South Bronx, Upper Manhattan, the Lower East Side, huge parts of Staten Island and so on had very high positivity rates. If you look at where people actually died, you'd see some of the same neighborhoods. But then the map and the deaths is the pinkish map in the middle, and then the light blue map on the right is the vaccinations. And here you'll see that the darker the blue is, the higher the vaccination rate. And you'll see those same neighborhoods had the lowest vaccinations but the highest infections and the highest deaths. And you'll see the places that had the highest vaccinations are largely white neighborhoods, including the one in the northern tip of the Bronx that is, unlike most of the rest of the Bronx, is about 65 to 70% white. That's called, the area is called City Island. And then this is a similar information around hospitalizations and death by zip code. You'll see the same thing. I guess what I'll skip over this and just sort of say, this map here shows, this was in 2019. This was data that came out in 2019 that showed the percentage of households without internet. So the dark purple represents households that were anywhere from 21 to 34% without internet. 21 to 33.4% of households without internet. And you'll see that it maps very closely over those same areas. A lot of the infrastructure, that because of those policies that denied funding and resources into those neighborhoods, meant that there's outdated infrastructure. It's much more unreliable, and it's not even widely available. and what is available is less reliable than what's available elsewhere in the city. It's not as well maintained. And this was in 2019. So just imagine with COVID-19, particularly in 2020 and also 2021, and the high unemployment that resulted from that. In New York City, literally hundreds of thousands of families had people not working anymore. And what that results in is obviously less income in the household to afford things like internet. But if you're setting up your vaccinations and your testing to be able to be accessed and registered for online primarily, and this is the percentage of people who before the pandemic 1/3 of the households did not have internet. We already know that it must have been way higher. I don't know what the data would show, maybe 50%, maybe 45%, 65% of some of these neighborhoods without internet access, just given all the economic issues that came out of COVID. And if we're setting it up to where this is how to, using the internet is how we access these life-saving measures, it sort of sets things up to where we know people are going to fall behind. So my point is just to say, in how we think about for all of us who are providers during that time or at the health department responding to the COVID-19 pandemic, these are the things that made our work more difficult. These are the things that make the management of diabetes in a patient much more difficult, childhood asthma much more difficult, and just across the board, mental health. Just want to point out that one framework that I've enjoyed using in thinking about this work is sort of looking at the public health framework for reducing health inequities from the Bay Area Regional Health Inequities Initiative, and sort of looking at what is upstream versus what is downstream. A lot of the work we do in health is very much downstream, focused on mortality, focused on disease and injury and risk behaviors, with that the interventions around that being those in healthcare, individual health education, case management. But what I'm pushing here today is for all of us to become upstreamists, to look further upstream, look at living conditions, look at the social environment, the physical environment. And a lot of this will then involve community capacity building, community organizing, civic engagement, working with elected officials, working with professional associations, healthcare systems, and others to sort of really do the work to improve what we see happening, and really recognizing the role of all of these coalitions of state, federal, local government, educational institutions, and others who all contributed to creating the mess that we're in and working together to reverse it. And then looking at institutional inequities and moving all the way up to social inequities. Leaning into community power, community wisdom. Our communities understand the issues. They've lived them. Many of us have only heard about them, or maybe read about them, or maybe even researched them. But our people have lived through these things and have experienced them, and we should be listening. We should be hearing what they have to say. We should be incorporating them and bringing them in really in a way that shifts power, that allows them to inform us and direct us and the work that the resources that we have, so that we are wielding the privilege and power we have to support that work. And then community healing and restoration, and really reframing how we think about the work that we do and where we place ourselves in that work. How we see that we are not just providing quality, compassionate, data-informed, research-informed healthcare delivery, but we're really thinking of ourselves as understanding that the patient in front of us comes from a community that has been harmed, a community that has been traumatized, a community that has been marginalized through many of the institutions that we now work in. And although we are not doing those things necessarily at this time, that we have a duty to reach back and work to dismantle and undo those things that we are dealing with. And then as I close, the idea here is complex problems really do require a collective approach. I mentioned this already. It was a collective that created the mess, and it will take a collective to fix that mess. And so just thinking about if we move from an isolated impact and everyone trying to do their own thing to a collective impact, and not just collective impact among health professionals and health researchers and health policy people, but the community, bringing in the community, not just community-based, but community-partnered, community-led, with a co-creation model, a shared leadership approach that allows us to do this work together. And then I'll lastly close with humility. And Angela Glover Blackwell, one of my heroes, was speaking at the Collective Impact Forum a few years ago and had this beautiful quote where she said, "It is so important for those of you who are beginning to do collective impact to know that when you are doing it right, you are joining a community that has been waiting for you, and to come with that humility." It's a challenge. It can be a challenge because for many of us, we spent many years gaining skills, gaining knowledge, gaining training, and then doing the work. And and society imputes to us this prestige and privilege, and we come with a degree of power, and so on, that we come into these conversations. But it's important, number one, to diversify the pool of people so that we have more people who are in that space with that experience from the communities that we want to serve and want to do a better job serving, whether it's rural communities or low-income communities of color in cities, whatever the case may be. It's important for us to diversify with people of different backgrounds, but then also know that when we come in, those communities' voice must be amplified. The communities' voices, we must share power with communities, and where needed, we need to shift power so that the communities are able to, and not just come in and task shift and give them work to do, as we see it. And with that, I thank you all for your attention. I thank you for the time, and I also again want to congratulate the groups, the teams that will be receiving awards today, and I wish you all the very best. Thank you.
Thank you so much for that informative talk, and really sharing with us our history. It is so important that we understand our history so that we can have a better placement of our current situation, and how it's so important that we bring in the community into these conversations of solutions. So we thank you for your time, and thank you for helping us to really move forward in this work. And it really leads nicely into our next portion of our program, which is Caring in Our Community. And we're going to hear now from Che Anderson and John Irwin.
Awesome. Thank you for that. Thank you for giving us an opportunity to talk about what's happening here in our community. We do want to mention that while we're going to highlight a few of the things that are happening in the office, that many of the faculty, staff, and students on campus have been doing an amazing job finding ways to still engage the community, particularly over the last 2 years, where it's been extremely difficult to have connectivity and find ways to safely get in front of people, but we've done it. And as a framing thing, as we're here to honor the legacy of Dr. King, a quote that I thought was very pertinent right now from him was, "Life's most persistent and urgent question is, what are you doing for others?" And that perfectly ties right into starting here. For those of you that may not be aware, we had our vaccine corps, which is a collaboration between UMass Chan Medical School, the city, Commonwealth, Worcester State, and St. Vincent's, Commonwealth Medicine. And really the one thing I want to mention here is that within the 4 months that this facility was open, this opportunity for us was open, there were 1,700 unique volunteers and over 83,000 vaccines were administered, which is a staggering number to really show the dedication that our team here had, with some great leadership from the chancellor himself there, who was there administering vaccines. Next slide, please. Through the Worcester Refugee Assistance Project, what some of you may or may not be aware of is that due to Operation Welcome, the United States has seen an influx of Afghan refugees. The city of Worcester had over 1,000 that have come to our community. And while our campus here has been sort of involved since the onset of trying to figure out ways to best help them reestablish themselves and resettle through a lot of the work of our students, we've done COVID testing for the resettlers, as well as assisted in finding ways to get them permanent housing within our community and welcoming them to be new Worcesterites, if you will. Next slide, please. Next slide, por favor. There we go, working for Worcester. As an alum of the College of the Holy Cross, very near and dear to my heart. But working for Worcester started back in 2012. And it's a student-led initiative to find ways to engage public spaces, playgrounds around our schools. And so this was a great opportunity for, again, us to get together safely and build raised garden beds at North High School, which is part of our North Quadrant support network and support services network. And so it was great to not only be out there with, again, faculty, staff, and students, but our mayor of the city of Worcester, Joe Petty, came down and helped us. And I learned that day that I have whatever the opposite of a green thumb is. So that was fascinating, and John can attest to that. Going to our next slide. North Quadrant Support Services. Many of you are aware of this through the work that's done for our CARES program. One of the things that we wanted to highlight was our backpack assembly and distribution. And I know that some of you will probably look at that and go, you know, why is that the particular slide that you focused on for all the work that we were able to do within the North Quadrant? And the reason for that is you would be surprised at the staggering amount of students that don't have a backpack for that first week of school. I know for some of you, you may think, well, like, of course kids have a backpack. They don't. They're children that will come to school with plastic bags or other amenities, or just carry their books and supplies by hand. And so to show up, you know, with a backpack, and candidly show up with one with our logo on it, I think not only reaffirms our dedication to the schools there, but also shows the students that there's an opportunity and a pathway forward, and gives them something to aspire to, right? It's amazing to go from your first backpack being from UMass Chan Medical School, and hopefully a decade or so later to be a student at the school itself. So that's a great way to, you know, sort of provide opportunity and inspiration for young people in our community. Next slide, please. The Regional Environmental Council, which is amazing work, particularly as more people have learned around the instability we have around food security, not only in our community, but in our nation. So they were able to partner with many of our students on campus and planting a student-led community garden. And this is actually one of the first times I myself got to campus as a new hire. And so it was amazing to see the students out there giving their time and energy outside of their very rigorous schedules to find ways to provide new opportunities for other members of our community. And I know this is just a really quick snapshot, but I do want to mention that there's an initiative that we have on our campus, a program that is part of a national network called Collaboratory. And what that is a program that allows you the opportunity to go in and see all the community-based work that's happening. Right. And so I just want to give a big shout out to Dr. Evelyn Haley, who's been really leading that effort, finding ways to get people on campus to enter their information. And so if you haven't entered information, or if you have information to enter and haven't been addressed yet, you can definitely contact her, and we can find ways to get all of the amazing work being done on our campus uploaded so we can get a really great snapshot of what's happening. And I think that's my time. No one wants to hear more from me. So I'm going to pass it over to our Vice Chancellor of Government Relations, John Irwin.
Thanks, Jay. As you can see, members of the UMass community are out and about in Greater Worcester and beyond, making a real difference in people's lives. With those examples in mind, and in keeping with the theme of today, remembering through service, I'm pleased to announce that we will be launching soon an expansion of our UMass Chan Cares initiative to include a volunteer service component. This new initiative will provide employees up to 16 hours of paid time off per year to volunteer during regular business hours. And it will help us expand and enhance our current partnerships while developing new ones. There's also an employee well-being component to this. Numerous studies have shown that volunteering can increase resiliency while reducing stress. Those participating in the new volunteer initiative will be able to choose from literally hundreds of organizations, as well as UMass Chan Care initiatives, some of which Jay highlighted, the Vaccine Corps and some of the work in the North Quadrant services. So look for more information on how this works, the kind of the mechanics of it in the next couple of weeks. But again, this is, I think, a perfect opportunity to celebrate what we're doing now, and obviously expand upon some of those partnerships we have. Now, I think I'm turning it over to Dean Flott for the annual Student Service Awards.
Yes, thank you very much, Vice Chancellor Irwin. I have the privilege every year to announce the Martin Luther King Jr. Semester of Service Student Awards. These awards are actually enabling opportunities for students to participate in service. And the alignment with the Martin Luther King Jr. celebration makes perfect sense as we work together to participate in the solutions to some of these very, very difficult problems that Dr. Manindo mentioned in his keynote talk. I'm often reminded at this time when we think about all this positive work of the quote from Dr. King, "Darkness cannot drive out darkness, only light can do that." Hate cannot drive out hate. Only love can do that. And these are some students from all three schools trying to provide some light and some love to their communities and to the people around them. So I think we have the individual awards listed as we come forward. So the first award is entitled Improving Pediatric Oral Health in Worcester. In this project, 6 oral health education sessions are being held at a diaper outreach program, and this will increase awareness about the importance of oral health, actions that they can take to improve oral health, and the resources to schedule a child's first dental appointments. And the students who are leading this initiative are second-year medical students Fiona Splain, Ekaterina Skaratanov, Marie McGordy, and first-year medical students Jack Hanna and Nadine Creedley, and also joined by MD PhD student Jillian Belgren. Their community partner is Marie's Mission. Congratulations to those students for this wonderful project, and hopefully getting those children on a lifelong journey of better oral health. Next project is Moving the Walls, Enhancing Interprofessional Care and Patient Privacy in Free Medical Clinics. The Tan Cheng Fen Graduate School of Nursing students involved in this will be integrated into the Worcester Free Care Collaborative, and adjustable walls will be purchased to afford more privacy for medical evaluations and discussions between patients, volunteers, students, and medical providers. The student volunteers on this are first-year nursing students Angela Patterson, David Runyon, Jillian Stacy, Courtney Montilla, Morgan Hill, Jacob Waldman, Cassandra Gale, Emily Dillon, Josan Narula, and Rachel Odilia. And their community partner is Worcester Free Care Collaborative. Congratulations to you. And then the next project, next awardee, Worcester Cares, caring for Afghan refugees through educational support. You heard about this a little bit in the earlier presentation about the influx of Afghan refugees. In this program, a K through 12 student tutoring program will be focused on school preparedness to mitigate educational disparities during resettlement while continuing to support the endeavors of community partners, including a patient navigator program and improving access to vaccines and other resources. It's led by second-year medical students Sahar Pirzad and first-year medical students Sumaya Akhtar and Michael Alou. Community partner is the Worcester Islamic Center Social Services. Congratulations to you on this very timely project. Next slide. Setting the Tone is also a very meritorious project. This project involves developing and delivering a series of educational lectures on clinical signs and symptoms in black and brown skin. And this will create a lasting clinical teaching resource, including distribution of bandages in a variety of darker skin tones. It's led by third-year medical students Christopher Fay and Jeremiah Heislip, second-year medical student Christian Keenan, fourth-year medical student Nichita Kulkarni, and first-year medical students Zaheen Ahmed and Sumaya Akhtar, as well as MD PhD student Webb Camille. The community partner is the Family Health Center of Worcester. Congratulations to you for these budding dermatologists. So the last project I'll describe is called STEM Start. It is a new health career-oriented mentorship component that is going to be added to the established STEM Start program at the Worcester East Middle School to include a healthcare fair and a mentor panel comprising female professionals in various STEM careers, led by second-year medical students Naomi Stuffers, Annie Ma, and Lyle Sue, It partners with Worcester East Middle School as well. So congratulations to the STEM Start and to all 5 of our student teams who are part of the MLK 12th Annual Semester of Service Student Awards. Thank you so much. And now I believe that it is my privilege to introduce Chancellor Collins, unless Vice Chancellor Duncan has anything else. And Chancellor Collins will deliver the annual award for advancing institutional excellence in diversity and inclusion. Chancellor Collins.
Thank you very much, Dean Flott. Good afternoon to all of those of you who are joining today. It's nice to have the opportunity to be together with everyone. I want to especially acknowledge and thank our invited guest speaker, Dr. Noel Menyindo, for enhancing today's event and providing us with really very important insights into how each of us can advance health equity through a community engagement framework. I found his talk to be very insightful and interesting. I also want to take this opportunity to express my gratitude to Dr. Duncan and her colleagues in our Diversity and Inclusion Office for bringing us together for this annual community building tribute event, one that encourages mutual understanding, personal reflection, and corrective action. Dr. Duncan and her team have earned our appreciation for the great work they undertake day in and day out to foster a welcoming, inclusive, diverse, equitable, and high-achieving academic community here at UMass Chan Medical School. We're gathered virtually today for our 34th Dr. Martin Luther King Jr. annual tribute event. Each year, we bring new experiences and insights to this special event, which shape and give us a deeper understanding of Dr. King's vision, example, teachings, and enduring legacy. To appropriately pay tribute to Dr. King's legacy, it's incumbent upon all of us to take a moment today, and frankly every day, to engage in self-reflection and introspection, asking probing questions like, for what do we stand? How do our actions align with the values that we cherish? What can we do as individuals and as members of this medical school community to make the world we inhabit a better, more equitable, and just place? How can we more fully support and promote our neighbors and those vulnerable, marginalized, and overlooked in our society? In restless and uncertain times, the wise and prescient words of Dr. King act as moral wayfinders, helping to illuminate a fairer, more just, equitable, and harmonious road. As Che alluded to in his comments, let us use, according to Dr. King, life's most persistent and urgent question as our institutional GPS. What are we? What are you doing for others? Through our mission-aligned activities and efforts, we're doing a great deal for others. Consider that we teach and inspire future generations of physicians, nurses, and scientists. We perform research that offers hope and healing to people from all over the world. We care selflessly during an unrelenting surge in disease for patients most in need. And we share our expertise and invest our time and energy toward helping the communities in which we live and work. Our medical school community is so fortunate to have so many among us who passionately and purposefully contribute to these mission-based efforts, all of which help us to fulfill our mission to advance the health and wellness of our diverse communities throughout Massachusetts and across the world. This is a mission that in many respects seeks to respond to Dr. King's poignant question, what are you doing for others? While we have an abundance of community members who breathe life and meaning into our mission, there are some in our midst whose commitment to our institutional values and mission in service to others is truly exceptional and merits special recognition. It is within this context that I'm pleased now to transition to the announcement of the recipient of the 2022 Chancellor's Award for Advancing Institutional Excellence in Diversity and Inclusion. By way of very brief background, This award is bestowed annually upon an individual or group exemplifying the medical school's diversity, equity, and inclusion values, which include building an inclusive culture, increasing access and equity, improving cultural competence, and advancing health equity. This year, under Vice Chancellor Duncan's leadership, we had a robust nomination process with a large number of very strong nominations. I want to thank the nomination committee for carefully evaluating the nominations and for putting forward a terrific slate of finalists, any of whom is deserving of this recognition. This year, one nomination in particular stood out and proved to be particularly compelling. It's my privilege to announce that the recipient of the 2022 Chancellor's Award for Advancing Institutional Excellence in Diversity and Inclusion is Dr. Mary Munson, Professor of Biochemistry and Molecular Biotechnology and Vice Chair of Diversity in the Department of Biochemistry. Esteemed scientist, cherished mentor, collegial and collaborative team builder, and above all, an advocate for action that makes a difference, Dr. Munson, today we recognize you for your profound commitment to diversity, equity, and inclusion at UMass Chan Medical School and beyond. From multiple initiatives spearheading diversity in action on our campus to co-directing an innovative national program to enhance diversity in the academic biomedical workforce, your commitment that puts diversity and inclusion front and center in all that you do is laudable, impressive, and impactful. At the national level, you've worked to promote researchers from diverse backgrounds through your leadership in the Women in Cell Biology Committee at the American Society of Cell Biology, and as a co-investigator of that organization's Mosaic program, an NIH-funded initiative that facilitates the transition of promising postdoctoral researchers from diverse backgrounds into independent tenure-track faculty positions. Moreover, here at UMass Chan, you have similarly focused efforts to promote diversity and inclusion by co-founding a local chapter of the Association for Women in Science, co-founding the Interdepartmental Faculty Fostering Inclusive Excellence Community, serving as a faculty advisor for our student-led SACNAS chapter, and taking on the lead faculty role for the UMass Chan Voices in Science seminar series. Through all of these efforts, you provide a forum for diverse learners and scientists to present their work and develop connections throughout the UMass Chan community. Your colleagues admire your commitment to making a difference, acknowledging your boundless energy, vision, and persistence that have helped to heighten awareness and advance a culture of inclusion for continued key progress in diversifying our institution. You're an authentic individual with compassion and broad understanding of the impact of diversity, equity, and inclusion matters for UMass Chan. Persistently and consistently addressing barriers facing aspiring researchers from backgrounds historically underrepresented in science, you prove again and again that one person can make a difference for many. With compassion and broad understanding of why diversity and inclusion matters, personifying friendliness and encouraging fun along with hard work, you are an exemplar and an inspiration to all. Mary, congratulations on receiving the 2022 Chancellor's Award for Advancing Institutional Excellence in Diversity and Inclusion. Well, that brings together this afternoon's that brings an end to this afternoon's program. Allow me to once again to thank our speaker, Dr. Noel Manindo, Dr. Duncan, and the DIO team, our awardees, and all of you for attending this important program. As we sign off and head back to our responsibilities, let us all use Dr. King's question. What are you doing for others as a constant source of direction and measurement in our lives? Have a terrific remainder of the day. Thank you.